Well, thank you very much for the nice introduction and for inviting me to these rounds. It's amazing. I have been doing this work with Mayan communities for 2012, so it's been a while. What is it? Almost more than 10 years, right? Almost 15 years, more than 15 years. And I have never thought I should come to global health here, right? So and I really, really appreciate the opportunity. So I'm going to talk today about the impact of a community-based rehab program that we have been implementing in Mayan communities for a long time. But I want to, can we go to the next? Before I go, I'm going to do the acknowledgements, but before I go to the acknowledgement, just quickly, I want to use this presentation to demonstrate a new analytic approach that we're taking to do these types of projects. And I think that's what could be of value for the global health community to see that. That's why I'm going to focus on that. But first, I want to acknowledge the territorial acknowledgement. I acknowledge that we're located on Treaty 6 territory, and this is the official acknowledgement, land acknowledgement from the university, but I usually do it more personally. Is there, I don't think so, but someone here do you identify as indigenous on these lands? No. But if there is anyone in the audience who identifies as indigenous, I want to personally recognize that we are on your land, that I am a settler. I'm come from Mexico. I'm trying to understand the colonial history, and I'm trying to change the narrative and trying to become an ally of indigenous peoples. I have been working with indigenous peoples for a long time in Mexico, and here in Alberta, less time, but yeah. So I wanted to do it more personal. So the next one, please. So I have no personal or conflict of interest with the presentation I'm going to give today. And let's begin with the two objectives. So I have two objectives for you today. One is to introduce you to the concept of syndemics. Have you heard about the concept of syndemics? No one? Okay, so this is a kind of like a new concept. That's the new thing that I want to kind of share with you. We're still developing this idea, so I will love if you have any feedback, if it makes sense to me. Okay, to you, sorry. So I want to introduce you to the concept of syndemics as a concept that could help us to understand better the complexity of the interaction of having multiple health conditions in context of social disadvantage, right? So it's all about the social determinants of health. That is something that now I think in global health, that's our main thing. But this is kind of like bringing it to one step further in terms of analysis. The second objective is to exemplify the use of this concept in the work that I have been doing in Mexico, or we have been doing in Mexico, because it's a team effort, of course, to develop and evaluate a community-based rehabilitation program or a community-based program. So those are the objectives. Does that make sense? Okay, let's continue. So a little bit first about the global health context, right? So why am I here? What is my experience doing this? So as I told you, since 2012, we have been working in different Mayan communities in Southeast Mexico. Actually, when I did my PhD at McMaster, I went to live into one of these communities for a year to do my field work. And that's where I started developing this program of research. So I just want to give you some illustrations. As you can see, the two pictures there is kind of like giving you a little bit of the context of how does it look, right? The spaces. So that is a lady, let me just see. Yeah, she's working on manual stuff, like artisanal kind of job that she has. And I want you to look at the sidewalks of the community. So that's the type of environment. It's in the middle of the jungle. It's in the area of Yucatan. Have you been, please raise your hand if you have been into the Cancun area. Any one of you? Only one? Come on, really? So Cancun is right here. right here. So this is an interesting, so this is the state of Yucatan in southeast Mexico. Cancun is a small tip here. This is the ocean, the Caribbean Ocean. So these municipalities that you see here are one of the poorest in the country, and they are 300 kilometers away from one of the richest parts of Mexico because of the tourism, right? So the contrast is striking. That creates a lot of issues because a lot of people, like young people living in these communities, this is close enough for them to be exposed to that, right? And then migrating to the city and changing the whole issue of the community, but they are far enough for actually getting the benefits of the tourist flow. So that's why these communities are in this kind of like in the middle of a transformation, and we have been working with them. These are three communities. One is called Chancón, which is the purest one, this one here, and the other one is Yascaba. So this is what we have learned so far, right? So we have marginalized communities, as I'm telling you. So people like they're in the poverty, below the poverty line, in relationship to the rest of Mexico. They have a high prevalence of chronic diseases or non communicable diseases like diabetes and hypertension. But our approach has always been through musculoskeletal diseases. Why is that? Because this was known already, like in 2012. What it wasn't known was how prevalent were the rheumatic or musculoskeletal diseases, like your inflammatory arthritis, degenerative arthritis, like soft tissue injuries, right? Those we didn't know, but a big epidemiological study that we did before this showed that being indigenous was associated to having more diseases, more rheumatic diseases. So that triggered us to go into the field and try to understand that. And we found that, yeah, there is a lot of musculoskeletal disease on top of the chronic disease, right? The other known chronic diseases like diabetes and hypertension. And all of this in the social context of poverty was creating this phenomenon that we were studying and trying to understand, right? The next one. So after many cycles of situational analysis, development of programs, understanding, evaluating the programs, and then situational analysis again, this is what we have found is that, so we have our population here. So it's the Mayan Yucatecan communities. Xcalatzonot, Xcoptila, and Axuna are the most, like the biggest settlements there. So they have a high prevalence of diabetes and hypertension, so 10% of the population and 21%. Also a high prevalence of obesity, but also what we found is that they have a high prevalence of musculoskeletal diseases or rheumatic diseases, as you can see there. They have, so rheumatoid arthritis is at 2.4%. The global incidence of rheumatoid arthritis is 1%. So you can see that is a significant change. And for some reason, these Mayan communities are having inflammatory arthritis, which are severe, right? But also osteoarthritis is kind of high as well because they use their bodies to live. So that means most of these, like all of these, not most, all of these people live from agriculture for personal consumption, the food. So they produce their own food. But so you have been to Yucatan, but have you heard about a cenote? Any one of you, what is a cenote? This is small, like these caves where you have beautiful bodies of water, there are caves. You haven't seen that on the TV? Well, look at that. There are beautiful spaces. So the reason why we have these beautiful caves with water is because in that area of Yucatan, it's porous. It's very like the rock is very porous. So it's very rocky and all the water filters down and creates these spaces. So imagine trying to do agriculture, right, in this porous environment. So you actually have like this amount of land that you can actually put like a harvest or you can, like crop. So you cannot put machines in there. So these people uses the same techniques as the ancient Mayans to produce their food. And they have survived for thousands of years there, right? but without machines. So that puts a lot of toll on their bodies. But at the same time, we have the influence of the Western societies bringing all these kind of like processed foods, like Coke, for example. You will always find Coke there. You won't find a clinic, but you will find Coke, right? And those types of things have changed the way that their bodies react, right? And so we have been identifying all those things. But the most important piece that I want to share with you about this is that there is an exacerbation of the disease, and we have demonstrated that there are several publications about this, because of the unfavorable social context. And for me, because I'm in rehab, right? The most important thing that we have found is that there is a lot of disability. So people who are not able to work the land, meaning they cannot participate in a meaningful way. And if they don't do that, then they feel that their life is meaningless. That's the big problem. So yeah, maybe I'm biased because I'm in rehab, right? But to be honest, we have discussed this with people there and say like, yeah, we love that you have medicines, bring us medicine, that's great. We love that that you bring us this science and help us to diagnose our conditions. But at the end of the day, the so what for us is, if I am able to go back and work the land or do my roles as a member of this community, I will be happy. If not, I won't. They don't care about blood levels of sugar or pressure, levels of pressure, right? So of blood pressure, because that's the important thing for them is functioning. So that's why there was a very good match with us, like the disability and the rehab component. So now I'm going to, the next one, please. I'm going to share you two of my main frameworks of operation so you can understand the language that I'm using. The first one is, I use the International Classification on Functional Disability and Health. Are you familiar with that? Any one of you? You, perfect, good, excellent. So just for the context, like my definitions, right? So this is from the World Health Organization, 2001, and this is how we conceptualize functioning or disability. So functioning means that we have an individual that has personal factors, so who you are, your occupation, the things that you want to do, your leisure, etc. And that individual interacts with the environment. So where do you live, your income, the type of like work that you have, etc., the demands of the environment to your body. And disability, it's an interaction between these two, right? When there is a problem, either my body cannot respond to the environment or the environment is too demanding for my body, there will be a problem. And that problem is manifested as a dysfunction or disability at three different levels. One is the body functions. For example, pain is one of the biggest body functions, but it could be strength, etc. Then this, it could be at the level of activities, limitation of what can I do with that body. Like in general, for example, walking, everybody walks, or everybody moves around, everybody take care of your body, etc. And then participation, which is individual. So all of us here, we have different participations because we have different personal factors. So that means by participation, I mean those activities that make life meaningful to you guys. So for example, for me, I'm a physician, so my being a physician is my participation. If I cannot walk, right, I still can do it because of the type of clinical job I do. But another person who cannot walk, which a Mayan person who is a farmer, right? He cannot walk as I can't. But he is not able to participate because his occupation is to work this land that is poor, like rock, and cannot use any machinery. You see, so that's the difference. Both, we have limitations in our activities, which is walking, but I can participate and he can't. So that's how we conceptualize function. And the next one is the important piece for the intervention I'm going to present you, is the community-based rehab framework from the WHO. Have you seen this before? No. Okay, just quickly, in a nutshell, we have, the WHO says that a person with any type of disability on these three dimensions that I told you, right? In order to be able to participate in a life that is meaningful to them, they has to have, that person needs to have access to this, at least these 5 different components, each with 5 different elements. And these elements interact, and this is just theoretical, right? Interact with each other to actually give the magic result, which is, yeah, I'm able to be a physician, even though I cannot walk. So these components are the health component, education, livelihood, social, and empowerment, each with 5 elements. So imagine you want to build an intervention that builds with all these 25 components. How do you measure the effect of how do they work with each other? That is one of the biggest challenges we have in community-based rehab, and maybe that's why it hasn't kind of like this new proposal. So community-based rehab has been around since 1986. No, 1970 with the Alma Ata thing that happened. But then in 2010, there was a major review of this, and this is more based on the rights of people with disability to live a good life. But since then, if you look at the research production, it's really low. Why? Because it's hard to conceptualize all of these complexities. So what am I going to do? Where should we start? So as I'm going to show you, we have tried to do this, and of course, it's not. We're short always. We cannot do all of these things because it's so complex. So that's what we're trying to learn. So those are the 2 frameworks. Now let me jump to the examples. Okay. Also, no, before I need to define syndemics, right? Before I go to the example. So what is syndemics? What this could be a solution? So syndemics is a concept. So we have 3 pillars. First, or 3 assumptions. First is that the clustering and interaction of 2 or more health conditions. Remember, health condition is the ICF at the level. So for other people, when I talk about health conditions, they say, what are you talking about? Well, diseases. If you want to call it disease, it's a disease, but it's a health condition, right? When you have 2 or more of this, the assumption is that there will be a negative interaction, right? So your outcome is going to be worse than if you only have 1, okay? The second assumption is that this health condition interact and produce worse health outcomes. So if I only have arthritis, I will be better than if I have arthritis plus diabetes. That's the assumption, right? And the third one is that these negative interactions between health conditions are intensified by social, economical, political, and environmental factors. So you see the ICF environmental piece is recognized, and from public health or from global health, the structural determinants of health are recognized here, right? So syndemia, at the end of the day, is a concept that tries to bring everything together. So how? The next one, please. So what it said, what basically this concept is telling us is that we need, so far, we usually study disease only either on the burden or on the biosocial interaction. So what is it to be sick in a specific environment or in a bio-bio interaction? So what is it to be sick when I have more than one health condition? In the case of syndemics, they say we need to focus here in the interaction of the 3 things. And again, how do we do this, right? It's very beautiful, right? Actually, the syndemics, the whole proposal is by Singer. Singer is a medical anthropologist. So he's not a biomedical thinker. He's more like a humanities thinker, right? And she come out with this proposal of a concept. But again, the question is, how do we make this concrete and operationalized, right? So for me, these are the 3 main kind of like results of using a syndemic approach. 1, it forces us to have a holistic assessment, including health inequities, right? For global health, that's one of the biggest pieces, health inequities. In community-based rehab, health inequities is still the same. Now, but more operationally, it helps us to complete situational analysis. So you go to a community like this one in Yucatan and see what is the problem, right? And second, evaluate the effectiveness of these complex interventions. So I'm going to show you an example of how we have used the syndemic approach to do these two things. It's not perfect. We are evolving it, but I would love to see what you think, okay? So giving you the context, so this is, I'm going to present you results for our second big cycle of a community participatory research that we did in these communities that I showed you at the beginning in Yucatan. So we co-designed a program, right? By first doing a situational analysis, and then from there, co-designing a program, a community-based rehab program with some of the elements that I show you, some of the 25 elements. It's impossible really to do all without the amount of money or the collaboration with different sectors. And it was, in terms of research, has been informed by mixed methods or just qualitative and quantitative. So this cycle was more mixed methods, as I'm going to show you, okay? So just to give you more context, so the next one I think is going to be kind of like, we need to click and click. So the next one, so it started in Escalante, so keep that one. So we start in the communities of Escalante, Skoptail, and Yashuna. Those are our three communities. Now, we have a quantitative component and a qualitative component. The qualitative component is an ethnographic study. The quantitative component is a before and after observational study, okay? Next one. So the first things, we did a situational analysis. This situational analysis was based on, first, the quantitative piece was going to a census methodology on these three communities, knocking on the doors of all of the houses in this community to identify cases of musculoskeletal diseases that help us then to identify cases of other comorbidities, right? That is a flaw, and I will explain you later. In our previous census, when I was doing my PhD, we went through the whole municipality census, and it was 5,000 people. It was crazy. And that one, we included healthy people, so people that didn't have any issues with people who had issues. In this cycle, we just focus on people who had issues, recognize them in their houses, and then bring in a physician to confirm those diagnoses, okay? Then we go into the qualitative part of the situational analysis, not only about counting, but also about understanding, again, what are their perceptions, their narratives, the stories, how do they make sense of this disease, okay? The next one, please. Then we developed or co-developed the program by doing mostly qualitative stuff, which is like community engagement stuff, okay? And then the next one. And then we implemented the program so we can then evaluate it, right? So we evaluated it, so you can go. And again, using a mixed methods approach. First, it's the next one, please. The next one, yeah. So a descriptive analysis, information analysis, and the syndemic index. This is the new thing that I'm going to show you examples in the evaluation, right? So I'm going to show you two examples. One is how to use the syndemic index or the syndemia approach in the situational analysis. And then I'm going to show you how we use the syndemic approach in the evaluation of the intervention. Does that make sense? That's the essence of what I'm going to talk about, right? The rest, it doesn't matter. So we did thematic analysis on the qualitative stuff, the qualitative evaluation as well, that we're trying to integrate now in a mixed method fashion, okay? The next one, okay. So let's go back directly to the results of the implementation. I want to pinpoint some of the things so you can, I want to tell you the story so it makes sense to you, okay? Of course, we did much more, but I don't have time to actually go through it. So first of all, I want to get your attention to our number. So it was 513. It's much less than the 4,000 I told you from the previous cycle. Why? Because now we focus on the people who have already a disease that we detected with a disease. That is our population. So it's people who have some sort of musculoskeletal condition or some sort of comorbidity. I shouldn't say comorbidities, on some sort of other chronic diseases like diabetes and hypertension, right? So what you can see is basically there were 126 that were diagnosed with a musculoskeletal disease, right? But also we have other people, not necessarily with rheumatologic diseases, that had diabetes, hypertension, right? That's those two things. The other thing I want to show you is that the disability index, a 0.2 on the health assessment questionnaire, is considered to be severe disability, right? The literature varies on the interpretation, but it's telling us what we knew, right? Yeah, there is a high level of disability, there is a high prevalence of chronic diseases, and a high prevalence of specifically chronic musculoskeletal diseases. So nothing new here, right? We already knew that. So we did all this and we got the rest. It's doing this type of work. I don't know, have you done any of you have done community work, community research? It's hard, right? It's not like doing research even in a hospital or even, of course, not in a lab. It's really hard to get data. It's hard work working at 40 degrees Celsius in a community, in a jungle. It's hard. So why did we bother to do this, to repeat it? Well, because we wanted to understand and create with the community a new cycle of intervention. So the next one. So I will show you how we use the syndemic index for the analysis of the situational piece, okay? Go. So first, we start with these factors. We measure all of these variables, house to house, as I told you, in a census methodology. So socio-demographic, clinical, economical, environmental, and cultural, right? Then the next step is we did regular stuff, a logistic regression, just to see how much of these factors are associated to have a musculoskeletal disease first, right? Because we wanted to know, like, are these factors associated with someone to have a musculoskeletal disease? From there, we identify, okay, these are the variables that apparently are associated with that. So then we normalize them. So each one are on the same metrics, basically, right? We standardize those measurements or those outcomes, and then we aggregate it. So how did we do that? So what we did is this. So the aggregation ended up in a continuous value that we call a syndemic index, which goes from 0 to 1, right? All the way to 1, that means you have a syndemic. All the way to 0, you have lower syndemic. But it looks dichotomous, but we did it in a continuous way, right? We have a mathematician working with us who help us do all this stuff, right? So I'm doing my best to explain this. To be honest, there is mathematics in it, but the aggregation piece is, just imagine, you have these variables that are significantly related to having a musculoskeletal disease. So then you add them up. But how you will add them up? Well, first you need to see if for each variable, some of them are continuous, some of them are ordinal, some of them are nominal. So that's the piece of the standardization or normalization. He brought it to the same scale. And what you have in the same scale, he added up. So meaning that if you were towards that 1, that means that you have much more, you have more variables from the significant variables than if you were more towards the 0. Towards the 0, all the people have only 1 variable, or well, not less, because all of these people are in a kind of like sick, right? Well, not sick, they have health conditions. Okay, so that's the logic, right? And then what we do is, well, the mathematician does a network analysis. Are you familiar with network analysis? So network analysis are basically you just input a bunch of data, and each of these points is one of the participants, and then using, you put it on a space on a map, and based on different criteria, for example, variables of interest, you run it, and then you look at who is similar and who is not similar. So I see it like this. In regular, in health, right, in population health, global health, we usually work on aggregates, right? So means, standard deviations, medians, that's what we use, then we interpret based on, right? When you do that, which is what we did before, but then you transform it back to the individual. So instead of analyzing only from the group results, you analyze the individuals. And that way, but you want the filter and say, these are the variables of interest. So you don't see, otherwise you will be lost in this map. So you identify the variables that are of interest, and then you put them here, and you bring the data and analyze it visually as individuals, and then you implement other mathematical frameworks about distances, right, on the space to identify what they call clusters of people that are alike, clusters of people that are not alike, right? And that's the way then that you can see. So in this case, for example, you will identify the clusters of people who have more or less syndemia. So let me show you the results. So this is just an example. So you can see the odds ratio, so the group thing, of what are the variables that are associated with having musculoskeletal diseases plus one more, so having more syndemia. And you can see they make sense, right? Divorce, history of pain. Stone walls means that you have, you're poorer in this community, so that's an indirect measurement of socioeconomic status, pain, right? And on the other side, we have, even though they are still, the problem is the data, the sample size is not graded, but it's the census is what we have, right? The distribution is not great, but good mental state, being a widower, which makes no sense, right? Maybe being without a wife or a husband is better, I don't know. And plant-based roof, which is kind of another socioeconomic status factor, it was associated with protective. So these are the factors that were identified, and we brought them into the whole syndemic thing that I told you, the aggregation, right? So can you send the next one? And this is how to prove the hypothesis. Does this work? So this is people with negative for musculoskeletal diseases, and this is positive for musculoskeletal diseases. And you can see the syndemic index. If you have rheumatic diseases, the syndemic index, this aggregation that I told you, it's higher than if you don't have it. So this helps us to see, okay, for the situational analysis, the syndemic index works. And we were like, great. And now let's go back to the individual data. So this is how cluster analysis looks. And you can see on red are the patients with asyndemic, so more syndemic. So we put, of course, we have to dichotomize to have like high syndemic versus low syndemic, right? So the red ones are high syndemic. And what we can see is, okay, we can see with these colors on the left, there are distinctive clusters. And there are some clusters that have more people with syndemia than others, right? So you see, this is another analytic approach. We bring the individual data, and then we can go to these clusters and kind of like ask them, why are you different? So the next one, please. So this is what we found. For example, you see how we don't have anyone here with a syndemic, and what do we have there? Years of study. So that means that somehow in this community that is totally like the level of education is primary school, the more you study, the less syndemic you have, which makes sense. Well, okay, so even in these environments, that makes sense, right? But also the most important thing that I want to show you is that where the more syndemic people is here has to do with pain. So pain is really what brings these people together. So we were wondering, so why pain? Of course, pain because you're going to have a musculoskeletal disease, but remember, this is more about where you at in terms of these clusters. So these clusters are clusters of people who have more pain, and that's how we ended up saying, you know what? Maybe this is just a fancy way to say, yes, if you have a musculoskeletal disease plus more factors, then you will have more chances of having pain. And if you have more chances of having pain, you will have worse outcomes. So that's your syndemic, right? But then, so what? So based on this, we say, okay, so we need to do something to improve the pain, right? So that's kind of the simplistic way to see this. So that's why we created an intervention, okay? So this is the intervention of the community-based rehab program. How am I doing in time? Can you tell me?
10 more minutes anyway.
10 more minutes to go to questions. Yeah. So yeah, because I don't want to, as you can see, there is lots on here, right? I will go Oh, so I shouldn't go away from the camera, but this is the community-based rehab program. So in a nutshell, what we did is all together with the community, Mayan community, we created these different elements. This is our second iteration, as I told you. So in a nutshell, can you click it? So we went to, so there were medical care or rehab interventions. Basically was the connection of these people to rheumatologists and to physiatrists like me, either on visits, right, to the community or through telehealth, right? That was one of the biggest things. Why? Because we thought pain is our main target, right? The other big thing is it doesn't matter if you can see a patient if the patient doesn't have access to the medications, right? So the other piece, can you say, was this thing, like we hire people from the community to obtain and distribute medications that the state gives, right? So they are covered, right? But the problem before, they didn't have the means to actually access to these services. So now that is the key element of the interaction. So our health component, medical care, with the link of social component, which is assistance, personal assistance, which is through the figure of community leaders, so community, like paid community workers that help us with this, right? And of course, they help us to monitor when a person had issues. They connected directly to the rheumatologist or to the physiatrist to solve those issues. The rehab component that we did, the next one, please, wasn't that great, to be honest. That's a visit that we did with some physiatry residents, and we basically did joint interventions, but we did not stress, or we did not create a structural rehab component. And that was a difference from our previous cycle. That was a big mistake, because why? We just focused on the pain. We totally forgot about the importance of doing exercise, using physical therapy. That was a big mistake. And you will see the results, because in the previous cycle, we actually found more changes. So, and then we can see the next one was educational strategy, also that maps on the empowerment piece and the lifelong learning on the education component. And the next one, this is, yeah, and that has been always there, coordination with municipal authorities to help with the distribution of medication and also lab work. That's a big problem in this community. For a person to go and get lab work, regular lab work, let's suppose that it's a person with rheumatoid arthritis. They really need frequent lab work, right, to monitor the disease. To go there, it takes them 8 to 10 hours of traveling with people who are usually in pain in these different transportations. It's not great. So that's why people didn't go, right, or didn't have access to it. So the municipal government helped us and have been helping us we take the samples in the community through these community workers that are paid, and then they bring the samples to the closest city, and then we have the rheumatologist results. So that's one of the biggest things. Okay, let's continue. So basically, and these results, and so let me tell you the evaluation results. So remember I told you it was around 500, right? But we only got 154. So we were like, what? All of this effort? This is just because of incomplete data. So we're working with a mathematician on this. He's really pissed off, and I agree. It's a lot of work, and then to do all these models, they really require completeness of data. If you don't have completeness of data, you need to eliminate people from the model, and then you lose that. So we just rescued 154 of the 500. So we're really, really frustrated, but we're trying to improve this. But I will present you an example of how we have addressed this with this 154. So what we found, remember, first we do the aggregates. We know what is the difference between pre and post intervention. And we only found that grip strength, activity limitations like can you walk, can you climb, can you dress yourself, and participation in a very basic question is, can you do the things that you're used to do? were significantly changed and in favor of the people who received the intervention. But now the big problem here is, remember I told you before, we were comparing with healthy people who didn't receive anything because they didn't need it, right? And then we compare it with people with disease, but only one disease, right? That didn't receive anything. This model is people who have chronic diseases. The only difference is that one has MSK problems, the other one doesn't, but they still have a health condition. So this is a population with health conditions. So finding differences in things such as activity limitations is really tough, right? Really tough, because we didn't thought this through because we were just so focused on the situational analysis that then we forgot to say, well, but for the intervention, we need to have a different approach. Still using the syndemic, but a different approach to define. I would have done it, focus it on disability, for example, instead of focusing on the presence of disease, because the intervention is not going to change that. You're going to have the diagnosis of diabetes and rheumatoid arthritis even after the intervention, right? But that, you see, we are kind of learning the ropes, but still we got some results, right? And very interesting, no environmental factors were found to be associated with having the disease or having one or more diseases or health conditions. However, we just discovered a big issue. So we were like putting the cost, right? We assigned the cost of the medications these people were taking, and we found a difference that said that, and in the after intervention, the cost increased. But guess what? We were like, the cost increased, yes, but these medications are given by the public health system. So what this is showing us is that people are actually accessing more to medication, that it's, of course, it costs more, but the model is not going to tell you that. The model is going to tell you, oh no, the cost worsened, right? You have more cost after the intervention. Yeah. So we're trying to change that variable with the mathematician too. That's why it's important. We have weekly sessions with the mathematician right now to work this out, because of course they don't know, right? Like the mathematician knows about numbers. They don't know about the context or the clinical aspects of this. So we're working on that. I put it there just to give you a comment. So the next one. So again, as I show you, like in odds ratio, this is the pre and the post. I just want to tell you, like, bring your attention to two. So sorry, that's in Spanish because I don't have the software. So he just sent me the stuff, and so that starter is the also having syndemic. In this case, they having the MSK condition, right? Before it has to do with pain, right? So it's associated with pain. In the after, you see how it switched. So pain is here, and now it switched to the other side. It's still the big issue, sample size, because of the confidence intervals are still very wide, right? But there was a switch. So there is an interpretation that pain, I believe we did something in this cycle of intervention to decrease pain, and that showed also on the dressing thing. So the smiley face there. So it was already, the estimate was already in favor. So remember, this side is protective, this side is against, right? Of being worse. And it became a little bit more protective. But still, look at this. This is just the loss of data, right? Which is really, really, that's what we're dealing with. Okay. So again, we follow the same thing. We identify the factors, and then we move on. And we say, so pain and dressing are the ones that are apparently changed. So that's one conclusion. But then we wanted to know more, right? We continue on this syndemic thing. So we created the sum of factors, as I told you, right? And then we put it together using the HEPI. HEPI is actually the software that helps you to do this mapping and network analysis. Can you go? And this is what we have, right? So we have a network analysis pre and post intervention. So visually what we found is on green are your positive cases of MSK plus another disease. So the endemic, which again, I think is a mistake, but at least we can see some. So most of them are here in the pre, and in the post, there was a clear division. So something happened here. So after the intervention, so one of the things that and you can see that it's not the cluster between people who have the syndemic or the problem and people who doesn't is not that clear. In the intervention, gets a little bit better. And when we went in depth, what we found is that these are related to the people who actually have musculoskeletal diseases that improve their pain, and other people that didn't have musculoskeletal diseases, but they did have more than one chronic condition. And the pain there was not as important. So what we're doing right now is we're going to explore the narratives of these individuals, right? Because we did a qualitative study as well, to see and give us further understanding of why these clusters changed, right? So that's where we're at right now. We're still, the story is not over, right? As I tell you, weekly meetings with the mathematician to help us to get to a good conclusion about what happened after the intervention. But this was just an example. Next one, please. Just an example of how to use this approach of syndemics. So limitations, as I told you, incomplete follow-up data. We're really mad about it. High uncertainty around the variables because of the sample size, and we are still integrating the qualitative data. I think that that's going to be, for this cycle, qualitative data is going to kind of rescue our interpretations, because we lost so many participants due to incomplete data, then we will have to rely more on the qualitative information. But the network analysis help us at least to identify those subjects, so we can go directly to their narratives, right? And so these are my conclusions, right? So the intervention, yes, I had an effect on pain and dressing, so an activity, right? Non-participation, that's a thing, right? Because CBR tells you is participation what we're after. So maybe we just need more time for this to show, right? So that makes, for me, that tells me that the medical and the rehab interventions were the most effective, which, yes, at the end of the day, that's what we focus our plan, right? But we're very short. We need much more to actually see a big change in this endemic or a big change in the way that people like function in this community. So we need to explore further the clusters that, as I told you, and but at the end of the day, I hope I have demonstrated that this is an approach that we can take to these complex scenarios in global health, right? So finally, future directions, improve the rehab component of the matrix. Again, we forgot about it, and we already know that that works. We need to recapture it for the next cycle. Add the empowerment component. Empowerment component has been very difficult to do, but I'm convinced that if you empower an individual to take care of their health and their families to take care of their health, all of the other components are going to be integrated. I have been thinking about this a lot, and data is showing us that in community-based rehab, empowerment is the key. Once you have empowerment, then the other elements are going to be integrated, because it's the person and their families who are actually going to be more interested on integrating different services than as a healthcare system, right? Continue working on the sustainability, integrate more environmental factors. Again, we need to refine the model and refine the analytic approach, integrating qualitative data. So that's it for me. I just have some acknowledgements. Most of this work was done. The field work was done by 2 PhD candidates in Mexico. So Emilio and Cynthia. So I want to recognize them, and of course Alfonso, who is our mathematician, who's working with us and helping us to make sense of this approach.